Welcome to our final topic that we'll be covering for the cardiology block, chapter 4, hypertension. So, in this, we'll be going over what is primary hypertension, secondary hypertension, then the different classifications of hypertension according to John Murtagh, and the different traps the AMC is going to place for you to fall into, and then ways to avoid it, the drugs, the treatment, diagnosis, and the long-term management for these patients with hypertension. Now, to start off, hypertension is a very common disease, and it's a serious community disorder, and it's known as a silent killer because most people with hypertension are asymptomatic and unaware of their problem. Epidemiological studies have demonstrated that the association between hypertension and stroke, CHD, kidney disease, heart failure, and atrial fibrillation. And speaking of this, we'll also be going over the hypertensive emergency and hypertensive urgency as well, and how do we, what's the algorithm for treating those patients. All right, and target organs that can be damaged by hypertension are going to include the heart, then kidneys, retina is the most important one, blood vessels. Kidneys is also very important because of the changes in kidneys filtration rate. The GFR is going to be affected, and because of that the drugs that the patient is on have to be altered. And also sometimes selecting the drugs is also going to influence the kidney function, because some drugs, as we'll see later on, such as ACE inhibitors and ARBs, are renal protective, and that's the reason they get used. All right, so hypertension is the most important modifiable risk factor for CVD, and it's a precursor for stroke, ischemia, ischemic heart disease, heart failure, AFib, and CKD, and vascular dementia. All right, and they're going to test us about the hypertension from the diagnosis, if it's primary, secondary, the different treatments, and the different age groups, and how do they get affected. All right, so the epidemiology for this is not very important. However, it's, I've stated it because of just these two facts, that primary is the most common, 90 to 95% cases, and secondary is 5 to 10% of the cases. All right, and white coat hypertension is seen in 1/4 of the patients. And annual BP checks for all adults above 18 should be every 2 years if normal. All right, so remember this, because screening and screening timeline is very important for AMC, because they will give you options if the patient has any symptoms, or the patient's blood pressure is elevated, then what could be the screening timeline for them. And a lot of questions come on them, not just for hypertension but all of the diseases. So now we're coming to the classification that it's optimal is less than 120 and diastolic is less than 180, and this we recheck in 2 years. Now if it's normal, that means it's between 120 and 130, and diastolic is 80 to 85, then we reach 80 to 84, we check in 1 year, and we give them lifestyle advice. All right, now high normal is between less than 140, so 130 to 139, and 85 to 89. Recheck in 1 year, lifestyle advice, and treat if high severe risk. Okay, so if they have any risk factors that give them cardiovascular diseases to be found later in life, then we treat this hypertension as well. Now coming up to the different gradings, and this is important because the different gradings tells us the different screening and follow-up actions that we need to do to those patients. So mild would be between 140 and less than 160. That's how I like to remember. So you see that from here to here was a jump of 10, jump of 10, jump of 5, jump of 5, but now we're jumping 20 units, and here 10 units, and that's grade 1. So confirm within 2 months, 3 to 6 months lifestyle trial, drug if needed. All right, so we give them some lifestyle advice and see if there is any changes in those in these readings or not. If not, then we give them drug recommendations. So between 160 and 180, so 179, we have evaluation within 1 month. All right, with pharmacotherapy is most likely to be done for these patients. So 160 and below 180, and 100 and below 110. Right, severe anything above 180, and diastolic more than or equal to 110, and you have to evaluate within 1 week, or we have to evaluate within immediately and give them some therapy for this as they present. Usually we don't give them any therapy. We don't. So the reason it's written that we have to evaluate within 1 week or as soon as possible is that we don't go off just one reading to treat the patient. Later on we'll be going over that trap that the AMC is going to set as well. Now, isolated systolic hypertension is when the systolic blood pressure is the only one that's elevated, so that's just the isolated systolic increase, and the diastolic is going to remain normal at less than 90, right? And this is more commonly in elderly. Treat the same as drug principle applies. All right. Hypertensive emergency is more than 180 by 120 plus target organ damage, and urgency is more than or equal to 180 without by 120 without target organ damage. All right. Because urgency is something that so the way I like to remember is that for emergency you have to call the emergency services like the ambulance just to take the patient to the hospital as soon as possible. Whereas for urgency, we can give them oral agents and gradual reduction from 24 to 48 hours. Whereas for emergency, we call the ambulance, get an IV done, and then we have to manage their blood pressure as soon as possible. Then for malignant hypertension, it's going to be blood pressure more than 120 plus retinal exudates and papilledema. All right. Because the exudate is because of the exudative vasculopathy in retina and kidney circulations. And then you have refractory hypertension where the person's blood pressure is 140 by 90 and despite maximum dosages of 2 drugs for 3 to 4 months. So it's refractory hypertension. All right. Anything more than 140 by 90 despite maximum dosages of 2 drugs for 3 to 4 months. And we have to reassess secondary causes and see if it's actually secondary hypertension or not. All right. And another important fact is to check for compliance on taking those drug. All right, especially for spironolactone, because spironolactone is going to cause them to pee a lot and patients don't like that. If the patient has a cough, they won't like taking ACE inhibitors, so we have to check for compliance always. All right. So as I was stating this point earlier, that diagnosis should not be made on the basis of a single visit. An initial raised BP reading should be confirmed on at least 2 other visits within 3 months. All right, so we need a total of 3 readings in 3 months to confirm them. All right, the only exception is going to be grade 3. All right, with target organ damage. So organ damage, that means we have an emergency. All right, treat at first presentation always. Okay. Now moving on to the secondary hypertension recognition and investigation for those. So what Murtagh says is that it may suggest by onset below 40 years, all right, or by the history of the patient's physical examination, severity of hypertension, or the initial lab findings. Now, usually hypertension comes on later in life, in the last third of life, close to above 50, 55, from 60 onwards, it's more common. So if you're a patient who is really young, then you have to think that maybe it's a secondary hypertension, all right? And it is also more likely where BP is responding poorly to drug therapy and in accelerated or malignant hypertension. So the most common cause of secondary hypertension are various kidney diseases, all right? And proteinuria, hematuria, CAST means glomerulonephritis. Bilateral kidney masses could mean polycystic disease. History of claudication plus delayed femoral pulse could mean coarctation. And progressive nocturia plus weakness, we have to check for potassium because this could mean there is primary aldosteronism. And obesity plus snoring plus daytime sleepiness could mean there is sleep apnea. Paroxysmal hypertension plus headache plus pallor, sweating, palpitation, pheochromocytoma. Now, pheochromocytoma, I've seen a lot of questions being assessed based on pheochromocytoma. All right, we'll be going over what pheochromocytoma is in the endo section, but it's just a tumor that's also releasing hormones and that alter the blood pressure and a lot of the physiological function of the body. That's why we have paroxysmal hypertension, pallor, and sweating. All right. Now, essential hypertension, which is also primary hypertension, it's 90 to 95% cases. Gradual onset, family history, age is more than 40 with no specific clues. And then investigation, you have to exclude secondary causes. And treatment is lifestyle. So lifestyle is always going to come first, and then we have antihypertensives. Then coming to the secondary causes, the first one we have is renal parenchymal disease. It's seen in less than 3%. In the signs and symptoms in the clinic, we'll have proteinuria, hematuria, urinary cast. The patient has diabetes mellitus, recurrent UTIs, family history of polycystic kidney disease. All right, and the investigation obviously is going to be urine related. However, we won't do any Doppler or ultrasound for these. The bladder ultrasound for these patients, because we don't suspect any stones. And again, it's solely based on the history of the patient. So if they have a history of polycystic kidney disease, you will obviously do ultrasound of the kidneys, so renal ultrasound. You have to check for UEC, urinalysis, EGFR, and albumin creatinine ratio to check for osmotic pressure of the body. Then for treatment, we have to treat the underlying disease, and ACE inhibitors and ARBs are the drugs given for proteinuria. All right. Now, renal artery stenosis, again, it's less than 3%. We will see abdominal bruit because of the stenosis of the abdomen. So renal arteries are divisions of the abdominal aorta, right? So abdominal bruit will be seen. There is resistant hypertension. All right. As we studied above, resistant hypertension was giving 2 medication with the highest dose. We don't see any changes. All right. Then we have flash pulmonary edema. Suddenly there's going to be pulmonary edema, worsening of renal function with ACE inhibitors, which is known as the captopril effect. All right. And elderly, atherosclerotic, or young female. That's where we'll see these the presentation of secondary hypertension in elderly with atherosclerosis or with young female, and this is seen because of fibromuscular dysplasia. Then again, if it's kidney, we have to do these investigations. So if there's a stenosis, we have to do Doppler, and this is common for cardiac as well. So if we have mitral stenosis, we have to do Doppler imaging. Then you have to do CT and MRI angiography, which is the definitive diagnosis for this. And the treatment would be, because it's an artery stenosis, we have to do angioplasty and stenting, ACE and ARB with caution. All right, because if there is bilateral RAS, then that is contraindicated. RAS is renal artery stenosis, so it's contraindicated. Now, primary aldosteronism or Conn's syndrome, it's 0.3 to 1%. So these are very rare. So as I said, that secondary hypertension, it's very rare to begin with. And all of these reasons are also rare as well. So hypertension plus hypokalemia, so less potassium. All right, and low renin. And we have progressive nocturia, weakness. You have to check serum potassium, because if the serum potassium falls too low, it can have very detrimental effects on the patient's cardiac and neuro outcome. All right, and in this, the key investigation is going to be aldosterone-renin ratio. If it's elevated, then you have to do screening test, and these include adrenal CT MRI, adrenal vein sampling, and differentiate between unilateral and bilateral. All right, so if we have unilateral adenoma, we do laparoscopic adrenalectomy, and bilateral, we do hyperplasia, we do spironolactones. All right. And coming up to the most asked, the two that are the most asked, pheochromocytoma and coarctation of aorta. Prevalence, both of them very rare, but the questions are not as rare. They'll still base it off of the fact that you're supposed to know this and you're supposed to answer those questions as well. Now, in pheochromocytoma, we use something as the 5 Ps. So paroxysmal hypertension, headache, pallor, palpitations, and precipitation. So that means a lot of sweating is going to be present in the patient. All right, they may have, which is, this is a good factor, that they may have postural tachycardia. That means if the patient is laying down and you make them stand up, they could suddenly have tachycardia, and they could have hypertensive crisis because of certain drugs or anesthesias because of pheochromocytoma. Now, the key investigation is going to be 24-hour urine metanephrines and catecholamines, so most sensitive for pheochromocytoma. All right, and the treatment is going to be alpha blockades first line. Then we have beta blockade, then surgical remover. Never beta blocker first, because then we'll have unopposed alpha activity that is going to lead to hypertensive crisis. So alpha first, so A first, and then B second, and then finally surgical removal. All right, now coarctation of aorta is rare, but I've seen a lot of questions about this, This is going to present with delayed or absent femoral pulse. BP is going to be higher in arms as compared to than legs, and I've recently seen, and I think in one of the March recalls as well, for coarctation of aorta in an infant of I think 6 weeks was the age, and they had given this exact symptom, that the femoral pulse BP was higher in the arms than the legs. And the way they phrase is that the pulse in the femoral was weaker compared to the pulse in the arms, the brachial pulse. All right, and this is known as the radiofemoral delay. And there's going to be rib notching on a chest X-ray. All right, the inferior rib scalloping from the collateral vessels. Then on chest X-ray, it's the best one, is that we'll have rib notching and figure of 3 sign. And obviously definitive is going to be echocardiogram and CT arterography. Then the definitive treatment for coarctation of aorta is surgical repair or percutaneous stenting. Then OSA or obstructive sleep apnea, it's the most common one out of all of these. It is because of obesity. Then we see snoring and witness apneas, daytime somnolence, and we have to do something called an Epworth sleepiness score, which is going to be high for obstructive sleep apnea because they can't sleep properly at night. And in this we'll see resistant hypertension as well. All right, and for this the study of choice is going to be a polysomnograph, and the treatment is going to be a CPAP therapy, which is going to reduce BB by 2 to 3 mmHg. Then drug induced is the most common one as well, and we have to do comprehensive drug history, OCPs, NSAIDs, corticosteroids, sympathomimetics, stimulants, amphetamines. So a lot of drugs are going to cause this. So you have to do a medication review, and you have to stop or replace those offending drugs. Now, just a rule of thumb is that for all of these AMC questions, when they say that this person started taking the drug and then suddenly had adverse effects, the treatment is going to be stop those drugs or replace those drugs. All right. Then Cushing syndrome as compared to Conn's syndrome. Now it's rare. There's central obesity. The normal symptoms for Cushing syndrome: purple striae, proximal myopathy, moon face, buffalo hump, eye bruising, poor wound healing. Then you have to check for urinary free cortisol overnight, dexamethasone suppression test, and morning cortisol. And the treatment is going to be to treat the underlying cause. If there's an pituitary adenoma, we have to do sphenoidal surgery. Now in this, for the urine test, we're checking for cortisol. All right. Whereas for where can I find it? For pheochromocytoma, we're checking for metanephrines, and for Conn's syndrome, we're checking for aldosterone renin ratio. All right. Now moving on to the clinical evaluations that must be done. So Murtagh test tells us that the initial investigations that are recommended are chest X-ray, plasma glucose, especially fasting, then serum total HDL, cholesterol, triglycerides, serum creatinine, eGFR, ACR, so checking the kidney system, then checking the serum uric acid, serum potassium, sodium, hemoglobin, hematocrit, and then urinalysis. Then he finally states to do ECG. And then echocardiogram if we especially are suspecting any coarctation or stenosis. Then carotid ultrasound for Broods, HbA1c again for glucose, fundoscopy in severe hypertension because of end organ damage. Then baseline investigation that must be done for all hypertension is going to be FBE, UEC. The reason why FB is done is because of two diseases, anemia and polycythemia, where the hematocrit is very low, so the blood carrying capacity is low. That means the blood has to move a lot to deliver oxygen and faster, so your heart is going to pump a lot. That could lead to hypertension. Then eGFR, because of renal damage, we'll have RAS system activation, and then we'll have hypertension. Then fasting glucose because of diabetes, HbA1c, fasting lipids, HDL, LDL, TG, urinalysis, ACR, ECG, and chest X-ray. You have to establish baseline renal function for drug monitoring, assessing cardiovascular risk, identifying target organ damage, and screen for secondary causes. Echocardiogram, most importantly, check for LVH as well as coarctation, LVEF if HF is suspected, so left ventricular ejection fraction if we have heart failure that we are suspecting. Now, echocardiogram to consider an evaluation for left ventricular hypertrophy is high CV risk, and we treat more aggressively. Ambulatory 24-hour BP monitoring, which is also known as Holter monitoring, to continuously check for BP recordings because of white coat hypertension. And if you don't know already, it's a type of hypertension that is non-pathological, where the person has hypertension because of being present in a room with doctors. So to go around that, we use we use Holter monitoring. So it's either white coat hypertension or masked hypertension. All right, and masked is the opposite of white coat. So the BP is normal because the person is in the doctor's office. All right, you have to check for BP variability as well, and nocturnal dipping versus non-dipping. So dipping and non-dipping is that the blood pressure during the night while the patient is sleeping is supposed to dip and then slowly rise towards their waking up time. However, some patients don't have that, and they're called non-dippers. So we have to check that as well. And we did actually a research on if it's better to give antihypertensive medication before sleeping or in the middle of the day. And the outcome we got was that it's better to give at the evening time. However, the only thing that is stopping a lot of, not just the only thing, but the reason that the drawback and future plan for that research is going to be to check for dippers and non-dippers, because we did not consider dippers versus non-dippers in that study. The outcome was better, to giving at night. However, we did not see if the dipper versus non-dipper was being assessed in the articles that we're considering. Anyway, so required for as Murtagh said, that the required for fluctuating levels, borderline hypertension or refractory hypertension, we have to check for ambulatory BP. Then fundoscopy is in severe hypertension in grade 1, arterial narrowing, silver wiring. Grade 2, we have AV nipping. Grade 3, we have flame hemorrhages and cotton wool spots. Cotton wool spots, it's a dead giveaway for hypertension. Grade 4, we'll have papilledema, and that means we have malignant hypertension. All right, grade 4, malignant hypertension, it's an emergency. All right, then secondary hypertension workup. So we do as we went over them in the previous section: aldosterone renin ratio for cons, 24-hour metanephrin for pheochromocytoma, renal Doppler ultrasound for RAS, sleep study OSA, thyroid function test for hypothyroidism, and drug screen. It doesn't state that we have to also do urine catecholamines. Yeah, anyway, so they are not routinely performed because, as we stated them earlier, we only do them based on clinical signs and symptoms. But these second reasons for secondary hypertension are not very common. So we have to first mark off the common reasons, then we move on to the uncommon ones. Then lifestyle management. So all of the disease will obviously have some lifestyle management. And for hypertension, first one is going to be weight reduction. So 2.5 to 1.5 mmHg per kg is lost. So target BMI is 18.5 to 25, and waist circumference for males is less than 94 and female for less than 80. And they could give you to calculate BMI in the exam, and then go from there that what are the different interventions that you'll have to place on the patient. All right, now moving on to the serum sodium salt restriction. It helps to reduce by 4 to 5 mmHg, so less than 100 millimole sodium per day, which is less than 6 grams of salt per day. All right, aerobic exercise 150 to 300 minutes per week, walking. Reduce alcohol intake to 1 to 2 standard drinks per day, and drinking more than 20 grams of alcohol a day raises BP and makes treatment of established hypertension more difficult. Then DASH or Mediterranean diet, rich in fruits, vegetables, whole grains, low-fat dairy, low saturated fat, high potassium and calcium. Then you have to, obviously, most important, smoking cessation. And elimination of smoking is important as a strong risk for CVD, and it may negate any cardiovascular benefits of antihypertensive therapy. CPAP for OSA, it's confirmed that it shows that it reduces BP and with those with OSA and hypertension. Even though if it's by small amounts, so we have to stack those lifestyle changes to get us, the best one, to get the best reduction in BP. Now, the final one we have is stress reduction. We don't know how much it benefits, so we just consider it's a small benefit. So relaxation, therapy, medication, stress management, etc. Now, moving on to the pharmacological management, we always start with a single drug at low dose, and a period of 4 to 6 weeks is needed for the effect to become fully apparent. All right, so 1 month, 1.5 months, it's essential for that. So if ineffective, we consider increasing to the maximum dose or adding a different agent from another compatible class. or substituting with drugs from another class. All right, use only one drug from any one class at the same time. So we can't give them, let's say, captopril and ramipril or betalol and another beta blocker. We can't give them verapamil and diltiazem at the same time because both of them are in the same class. All right, they usually require 2 or more agents to reach a BP target. Beta antagonists are not routine first-line treatment unless they will also be useful for a coexisting condition. We never combine ACE inhibitors and ARBs. All right, it's either ACE or either ARB. So we start off with thiazide diuretics, first-line drug classes, hydrochlorothiazide or indapamide. All right, and for elderly, so particularly recommended for the elderly with isolated systolic hypertension, mild heart failure, glaucoma in combination with other agents. All right, contraindications, so CIs are gout and hyperuricemia. It raises uric acid, hypokalemia history, and avoid in pregnancy. It's important that we do not give these to our obstetric patients. So ACE inhibitors particularly recommended for heart failure, especially for HFrEF, post-MI, diabetes, microalbuminuria or proteinuria, CKD with proteinuria, stroke prevention with thiazide. Progress trial is done because those of them are given together. Contraindication again is going to be bilateral RAS, pregnancy again because it's teratogenic, prior angioedema to ACE inhibitors, hyperkalemia. Do not combine ACE inhibitors with ARBs. Coming to ARBs, same indications as these, and if they are preferred if ACE inhibitors is inducing a cough, and the left ventricular hypertrophy regression can be seen because of these. There's no angioedema risk, however they're the same as ACE inhibitors, and do not combine again ACE inhibitors with ARBs. Now coming to CCBs, we give them in stable angina, PVD, Raynaud's phenomenon, because all of these drugs are going to cause vasodilation. Again, elderlies with isolated systolic hypertension, Afro-Caribbean patients, post-MI, if beta blockers are contraindicated. They are not for systolic heart failure, all right, because they cause peripheral vasodilation with mild negative inotropy. Ankle edema is a common side effect. Non-DHP CCB, so these were dihydropyridine CCBs, where these are non-dihydropyridine CCB, so verapamil and diltiazem. These are given in, again, stable angina, hypertension, and SVT. All right, over the last video we went over what was SVT and how to treat them. Again, atrial fibrillation, rate control when beta blockers are contraindicated, especially in asthma. All right, and they should not be used with beta blockers because they can cause severe bradycardia leading to heart block and systolic heart failure, second, third degree heart block, because they change the conduction of the heart. All right, beta blockers, they are given again post-MI. So which ones were given post-MI? There's one. All right, then we have post-MI and ACE inhibitors, and ACE inhibitors and ARBs. All right, so 2, 3, these are all post-MIs. All right, they are contraindicated for asthma and COPD, and second, third degree heart block, PVD, and brittle type 1 diabetes mellitus, that is masked, because beta blockers are going to mask hypoglycemia. All right, and we avoid all sorts of abrupt cessations, and they are not the routine first line without co-indications. All right, aldosterone antagonist, spironolactone resistant hypertension with Conn's syndrome. So aldosterone, these are given for secondary hypertension. HFrEF post-MI with left ventricular dysfunction. Contraindication again is going to be hyperkalemia, CKD, concurrent ACE and ARBs, because they are going to affect the potassium concentration. All right. And then beware of hyperkalemia with combination of ACE inhibitors or ARBs with aldosterone antagonist. Now this is a very important table because it tells us the different patient subgroups and the most tested pattern for the drugs that we have to select. All right. Now diabetes plus micro, so renal related ACE inhibitors or ARB always, because of renal protective effect of ACE inhibitors and ARBs. If it's post-MI, as we checked above, we have to give beta blockers, ACE inhibitors, and spironolactone. ACE inhibitors are only added if ejection fraction is less than 40. All right, target BP is going to be less than 130 by 80, and if the person has HFrEF, you have to give ACE inhibitors, beta blockers, spironolactone. Again, same post MI or HFrEF, you have to give the same. We avoid CCBs in this because they're going to worsen the systolic heart failure. Then for stable angina, we prefer beta blockers. Alternative DHP CCBs, amlodipine, because both of them are going to reduce angina and blood pressure. If there's atrial fibrillation and hypertension, we went over this in the arrhythmics class. We have to give them non-DHP CCBs or beta blockers, either or. And anticoagulation is based on Chadbask score. All right, stroke TIA prevention, ACE inhibitors and thiazide combination. This is the one where we start using ACE inhibitors and thiazides instead of beta blockers. All right, and asthma COPD, we avoid beta blockers and we use ACE inhibitors, ARBs or DHP CCB. If ACE inhibitors gives our patient cough, we switch to an ARB. Okay. Now for pregnancy, ACE inhibitors were contraindicated, ARBs were contraindicated. We use methyl dopa as first line always for pregnancy, then labetalol for second line, then nifedipine second line. So methyl dopa, beta blocker, again nifedipine, which is a CCB, right? CCB? Yes, that is a CCB. And we avoid ACE inhibitors and ARBs. So elderlies with associated systolic hypertension, we use thiazides or DHP CCB. So again, elderlies with isolated systolic hypertension, thiazide or DHP and CCB. Then for gout, we avoid thiazides because it increases uric acid. Instead, we use sartans, or we use losartan. Then for CKD plus proteinuria, ACE inhibitors or ARB first line. Why? Because they were renoprotective. Then we monitor potassium and creatinine carefully because the kidneys are damaged. If the patient has resistant hypertension, we move on to spironolactone. All right, we have to give 3 drugs. BP still more than 140 by 90, we have to add spironolactone. Then beta antagonists again are not routine first-line treatment unless also used for 4 coexisting conditions. So this is one of the most important tables in this chapter, most important boxes. Now again, moving on to the different patient groups and the treatment targets. So proteinuria, if it's more than 1 gram per day with or without diabetes mellitus, we have to get our BP less than 125 by 75. And this is the strictest target because of the heavy proteinuria. That means high renal and cardiovascular risk. All right. Now for associated conditions such as CHD, and diabetes mellitus, CKD and stroke TI, our aim is going to be a little bit higher than a little bit less than proteinuria, because proteinuria is very dangerous as it can have long-term harm on the renal system. So not just the harm on the renal system, but it will be more difficult to control the blood pressure from there. Now with associated conditions such as CHD, diabetes, mellitus, CKD, and stroke, our BP target is going to be less than 130 by 80, and ACE inhibitors and ARBs are usually the backbone agents. Then for general hypertension with no isolated condition, it's less than 140 by 90, and most of it is achievable by lifestyle or by adding 1 or 2 drugs. Then elderly, we have thiazides, I think so. With standard, so they don't have for elderlies with no comorbidities, the BP target is going to be less than 140 by 90 mmHg, but we have to see from case wise. Then we avoid over treatment because of orthostatic hypertension. That means we're going to risk fall, and that is one of the reasons for bad outcomes in the elderly, and this is something we have to heavily avoid in the elderly. Now elderly frail that are more than 80-year-old, we have to get them less than 150 by 90 because of late life deprescribing when age and frailty renders risk of treatment greater than benefit. Alright, we start deprescribing, so we have to reduce the drugs and we have to be careful that they don't fall. Alright, now coming on to this important topic of emergency versus urgency. Emergency is with acute target organ damage, whereas urgency is without acute target and damage. All right, Target and organ damage for emergency is going to be hypertensive encephalopathy. That means they're going to have a headache, confusion, papilledema, acute left ventricular failure, LVF, sorry, not left ventricular failure, but LVF, and pulmonary edema, STEMI and STEMI, hypertensive retinopathy, grade 3 to 4 of retinopathy, then aortic dissection, acute kidney injury with creatinine rising acutely. Then we have in pregnancy, we have eclampsia and preeclampsia. Then urgency is going to be headache without neurological signs. We have neurological signs here, which was confusion. All right. Then epistaxis, asymptomatic BP elevation, stable angina, and anxiety. Now the clinical setting is going to be emergency department ICU, and this we have GP or the emergency department, but it can be managed outpatient or short stay. Route is going to be IV with continuous beep monitoring, whereas for urgency we have oral hypertensives. All right. The rate of BP reduction should be gradual and reduce the mean artery pressure by 20-25% in the first hour, then gradually over 24 to 48 hours to save the patient from something known as watershed ischemia, and also sudden change in the MAP or the sudden drop in blood pressure, the sudden increase leads to vomiting, so we'll have a lot of loss of fluid as well. Then again for urgency we have a gradual reduction over 24 to 48 hours. Then the IV agents we use for, so IV agents for urgency not applicable. For emergency we have nitroprusside, which is most treatable, and IV labetalol with dual alpha plus beta block, IV hydralazine and eclampsia especially, so this is given in pregnancy, IV GTN for ACS plus LVF, and IV esmolol for aortic dissection, control heart rate and BP. So again, this is an important table because for each scenario specific we have a different management for that. Alright, for aortic dissection plus hypertension, target SBP is going to be less than 120 mmHg, heart rate is going to be less than 60 beats per minute. We give IV labetalol or IV esmolol plus sodium nitroprusside. We don't give them pure vasodilators such as GTN and hydralazine without beta block at first, because it's going to worsen the dissection. And eclampsia or severe preeclampsia, we give magnesium sulfate. It's neuroprotective and to prevent eclamptic seizures and it's not primarily an antihypertensive again. And for BP we give them labetalol, IV hydralazine or oral nifedipine. We deliver the baby with definitive treatment. All right. And hypertensive encephalopathy, reduce MAP, so this is an emergency. All right, we reduce MAP by 20-25% in the first hour, not to normal because of watershed infarction risk. Then we give them, after reducing MAP, we then give them labetalol or sodium nitroprusside. Then we do CT to rule out ischemic, to rule out hemorrhagic stroke. Then for patient with ischemic stroke and hypertension, we use permissive hypertension and we do not treat unless the blood pressure is too high. All right, because you have to maintain the penumbral perfusion, and the only exception is going to be if they're eligible for TPA. So thrombolysis, we have to reduce BP and before giving TPA. If the patient has acute MI plus hypertension, we give them GTN to reduce preload and afterload. All right, and plus a beta blocker. If no contraindication, the target SBP is going to be 130 to 160. So in this we give IV GTN plus beta blocker. All right, and this is given in acute MI and hypertension. To get the, so this is the one that has the BPs that we have to aim to get the lowest, because we don't have a lot of side pathologies associated with this. Alright, now moving on to the special population, as we said, we have white coat hypertension and then we have masked hypertension. White coat is elevation of the BP in the ambulatory, in the office of in the doctor's office because of white coat, and masked hypertension is that BP is going to drop because of being in the hospital, and to come around that we have to do a 24-hour ambulatory blood pressure monitoring. Alright. Yeah, if you have resistant hypertension, we do, as we said above, that 2 drugs for 3 to 4 months with the maximum dosage. You have to check for secondary cause, lifestyle factors, pro-hypertensive medications, and we add a spironolactone as the 4th drug. All right, we have to also check the compliance of the patient. Now, if you just have isolated hypertension where the systole is more than 1 or equal to 140 and diastole is just less than 90, it's most commonly seen in elderly due to arterial stiffness. We treat with thiazides or amlodipine, and the CV risk reduction as diastolic hypertensive treatment. All right, now for hypertension in pregnancy, we avoid ACE inhibitors, we avoid ARBs, and we avoid thiazides. We use methyl-dopa, labetalol, and nifedipine, and the target is going to be less than 140 by 100 because we don't want aggressive reduction or it's going to affect the placental perfusion. Then with hypertension plus atrial fibrillation as the most common comorbidity with AF, 60 to 80%. We read this in the arrhythmias chapter as well. We have to give them rate control using non-DHP-CCBs or beta blockers. So one of the other, we don't give them both together because then the rate is going to be very less, leading to bradycardia and could lead to cardiac failure. And along with these drugs, we have to also consider anticoagulate, and for that we have to see Chart-Vasc score. Now there's hypertension plus CKD, so anything with kidney, ACE inhibitors, ARB, first line. Target less than 130 by 80. Now AMC doesn't usually ask about the target therapy, but it's nice that you remember it so that you would know, how long should the treatment go on for. We have to also monitor the creatinine and potassium closely because again it's kidney related, plus we're giving them ACE inhibitors and ARB. And the acceptable creatinine rise should be less than 30% from baseline when we had started the ACE inhibitors. And when is ACE inhibitors and when are ACE inhibitors and ARBs contraindicated? When there is bilateral RAS. All right, this is important. Hypertensive plus gout, we avoid thiazides. We use ARBs, CCBs, or ACE inhibitors, either of these, because thiazide is going to raise uric acid, and if there is hyperuricemia, we have to treat it if it's symptomatic. Then if it's hypertension plus diabetes mellitus, the target is going to be less than 130 by 80. We use ACE inhibitors or ARB for first line, and we have CCBs or thiazide as add-ons later on. All right, we avoid high dose thiazides because they're going to worsen glucose tolerance, and we avoid high doses of beta blockers because they mask hypoglycemia and worsen insulin resistance. All right, now coming up to our last section, worked AMC MCQs. You guys can go through it and give them a thorough read, try to guess them, and see how many you get correct. If not, then just go back to the section and redo the section, and hopefully you understand it. All right, so this was the last chapter for our cardiology block. Later on, we still have pericarditis, we have ASD, VSD, a lot of diseases that are still overlapping with other sections, and we'll cover them later. Don't worry about it. So I hope this was a good revision section for you guys, and if you have any questions, drop them down below. Again, this chapter is the Google Drive link is going to be in the description, along with the WhatsApp group where we discuss recalls, and along with the group link to WhatsApp where we discuss the recalls and questions that people have, and the Google Drive link with all of these resources for free.